Welcome to the Game Changer Experience podcast. We're your hosts, Dr. Jeremy Pastor and Dr. Dave Kim. Today, we're going to talk about the difference between what a medical diagnosis actually tells us and what we actually care about when deciding how to treat your pain. Come check it out. You are listening to the Game Changer Experience podcast, where we talk about rehab, performance, and everything in between. This is where we help you navigate common questions and misconceptions in the training and rehab world. So let's talk about this infatuation with the medical diagnosis, I'll call it, and the kind of the common theme that people feel like they need to know, like, what is happening, right? It's like people feel very uncomfortable with the unknown, right? Mm-hmm. Even if it's not going to necessarily change the treatment strategy per se, there's like this innate desire to know what is happening. So I thought it'd be good if we kind of touched on, like, first, what is a medical diagnosis, right? How does it differ maybe from just like as a physical therapist, what we might necessarily care about? And then we can even touch upon a little bit about like how we do things a little bit different at Game Changer PT and why we talk a certain way. So like, Dave, how do you manage that conversation with somebody, when they're coming to you and they're saying something like, should I get an X-ray? Should I get an MRI? Like, should I see an orthopedist? So on and so forth.
Right. So I think labels are incredibly useful at times, but also not during others. I think we find comfort and meaning when we are able to attribute pain to labels and diagnoses, but this obviously inherently will create unspoken barriers to recovery. So let's briefly go over what a medical diagnosis is first. So that basically is a label that's created based off of a series of tests that are performed to describe and kind of pinpoint what disease, quote unquote, is happening. Now, those things are usually very black and white, but again, it doesn't apply to every situation out there because the human body is very complex. There's a lot of gray. So again, it's very common to try to label these things. However, we just have to appreciate that there are other factors in play always. So again, I'll first kind of talk about what it tells you from a PT perspective. So for medical, diagnosis, it tells you where something's hurting, right? Like what is hurting. It doesn't necessarily tell you why or how that happened though. So if we're looking at, knee tendonitis, what does that really mean, right? Like it means that the knee hurts there and the tendon might be inflamed, but in no way or shape or form does that tell us like, oh, like these are the reasons why that happened. And so this kind of leads down to patients kind of viewing their knees a certain way, right? Like people tend to refer to their knees as their bad knee because, their doctor told them they have tendonitis. But the better questions we have to also think and ask is, how did that doctor come to that conclusion, right? Like, are they just performing a series of special tests, which to the general population, these are just tests to, check the knee in different motions, right? Like we're going to give stressors in one direction, another, see if that elicits pain or not. But that primarily can't be the only thing that's dictating, right? Like why the knee hurts. Other tests they might do, manual muscle tests are very common. They're going to place their hand against, one part of the body and they'll be like push or pull. And again, that's all so very subjective. And I'm not saying that manual muscle testing is useless. It's useful in certain contexts, right? From like a neurological perspective, it's you need to check that, and that's useful. Mm-hmm. But when it comes to checking like, quadricep strength for the knee, it's like, all right, what if the practitioner is weaker or smaller and the patient is bigger, or vice versa? Like all of these little factors are going to influence like their perception of how strong somebody is.
Right, like talking about medical diagnoses, right? I think there's levels to it, right? There's the level to it that is 100% useful, right? If there's a complete rupture of the ACL, right? That diagnosis is going to tell us something very valuable because it's fairly predictable the direction that that treatment strategy is going to go, right? For the less extreme situations, like you said, like a tendinitis or tendinosis or anything along that continuum, muscle strains, right? Ligament sprains. Now you can kind of break this down into a couple different things. A lot of times the diagnosis is given because they have to slap a name on something. Right. Many times. And we can't generalize, right? We obviously cannot because every situation is different. But there's been many times where somebody will tell me that they have a diagnosis. And when I asked, well, okay, great. Was that confirmed with some type of testing? It's like, no, they just moved my limb around. And then basically pain in that region. Hey, in their mind, what is the least significant diagnosis that I can give this because they're having pain near that tendon? And to me, that's not a good enough reason to put that diagnosis on it because you need to always understand how the patient is receiving that information, right? To the clinician, it could be very benign, right? It could be like, listen, this is just a little tendinitis, and we throw around words. To the patient, it's, I have an issue with my knee. And now there's something structurally affected with my knee. There was nothing actually confirming that. And we can obviously dive into whether or not, if an X-ray or MRI confirm those things, even if that necessarily mattered. But a lot of times medical diagnoses are given purely because you have to bill for something. Right. Like,
and I think go ahead.
Yeah, no, I just like, and that's true on the PT side, right? Like there has to be a code, there has to be a diagnosis that we're billing for, right? So we have to put a name on something, but there always has to be that almost like that caveat of education to the patient where it's like, hey, listen, we're going to call this tendinitis because I don't think it's something significant, right? You're going to go to PT. They'll do their evaluation. They'll kind of dive into what might be leading to your pain. And almost like downplaying it to the patient so that they're not leaving the office having this significant perception of what that diagnosis means for them.
Absolutely. I think perception is incredibly important because it'll affect how they view their own selves. And that's ultimately going to lead to how successful the recovery is. So if somebody's already coming into me and they already have this mindset of, oh, like this is my bad side, it's always been my bad side, and you can't prove me otherwise. It's like, okay, now there's double or triple the work for me to help you unlearn that. Right. And again, it's just, when we're trying to like do something useful or perform in a competition, you're not going to go half-ass mindset and be like, oh yeah, like I think I can do it. Right. You're not going to perform as well versus if you get in the zone and you're like, yeah, I'm going to succeed. I'm going to do everything I can in my power to succeed. You're going to perform so much better. So this same thing applies to PT in that scenario. Now, when it comes to medical diagnoses, I think a usefulness in that maybe is it kind of points you in a direction to go. What I mean by that is like, again, when we bring it back to even PT school in general, things are taught very black and white. And the reason for that is because we need to learn something from a foundational level. If we're just fire hosed with all the gray, like we're not going to know where to put our foot down, right? We're not going to really fully understand like, where or what to base something off of. So I think it's a good starting point, but the medical diagnosis shouldn't be the thing that tells you how to treat a patient.
There is a trickle down effect to receiving a medical diagnosis, right? And there are some times like that trickle down effect is unavoidable. Like at the end of the day, if you have a concussion, like I'm sorry, I have to tell you have a concussion, right? Like I am not saying to withhold valuable information from anybody, but when I say a trickle down effect, I mean there is this cascade effect of when somebody receives a diagnosis and really receives a diagnosis in the absence of education or context, that could affect everything. And what I mean by that is I'll give a quick story and I'll try to make it quick. I have a patient who very recently saw a doctor who was a friend, right? And every time I hear that, it always scares me. But saw a doctor who was a friend, and there was no x-ray done, there was no MRI done, and I'm not implying that those things were even needed for her situation, but she was having some type of like nerve symptoms running down her arm. I think it was her arm, running down her arm, right? And listen, numbness, tingling, any of those types of symptoms are very telling that a nerve is involved in some way, shape, or form, right? Now, the problem with that is there's a lot of different reasons why we could have some intermittent tingling, why we could have some intermittent numbness that comes and goes specific to some type of movement, right? If we could downplay that and we could address that and not necessarily have that constantly plague somebody, like does what is happening really matter? I'm going to have my opinion and say, like, to me, no, it wouldn't. But unfortunately, this doctor wanted to tell this almost like they wanted to be the hero in the story and like kind of guess right. So he told the patient, like, this is very likely a herniation, right? And, I want you to get an MRI. Now, if you want somebody to get an MRI, that MRI is what would be telling you whether or not there's a herniation. And again, we're probably going to dive into whether or not that matters for some people anyway, right? But what this person hears is this doctor told me I have a herniation that is leading to my numbness and tingling. Now, a large percentage of people go on to the WebMD machine, right?
Ooh,
and right, because they were not provided with education, with context, with any understanding as to what that stuff means, whether it matters or not, right? Whether it's possible of changing. And you go down this cascade of, oh no, my doctor told me I have this, right? So now I'm afraid to do any exercise because I don't want to make it worse, right? I'm afraid to sit in this posture, so to speak, because I think it's going to make it worse. Every time I have numbness or tingling, I have to have this thought in my mind, like, is this going to be like this forever, right? And, I'm sure people listening to this are thinking to themselves, wow, I've had those thoughts in my mind pertaining to my injury, because that is what happens when you provide information without context, right? When you provide information as the skilled professional, because in our mind, we know what we're trying to say, but if we can't express it in a way where you hear us, right, the only thing that matters is what you hear.
Exactly.
Right. And that is the part that I get, I'll say, like, kind of triggered by, right, but really like upset by, is because then our first step is almost getting them to unlearn the information that they were just told, right? Not saying that somebody was wrong, but it's just like, wait a second, let's slow down. Let's slow down, right? First off, we don't even know if it's a herniation. There could still be a number of reasons as to why we're feeling this, right? So let's not go down this path. Let's take a wait and see. Let's see if we can make these changes, right? And then go from there. So when I say like a trickle down effect, I'm talking about mental, I'm talking about physical. And then when you make that physical change, like I'm afraid to exercise, I'm afraid to move, how do those changes then have the trickle down effect of further impacting something else, right? It's a never ending cycle of, when you eliminate things, it's going to impact something else, right? When you change things out of fear, there has to be some type of trade-off. And what if we could avoid that? So if we got back to the point that you were kind of starting to touch on, right? Like, we're talking about medical diagnoses and maybe like where they're relevant and where they might not be appropriate. So if we're saying that a medical diagnosis is not always necessary to kind of help guide our decision making, right? Like, what is?
Mm-hmm. Yeah. So what is? Good question. A series of tests for us. And the reason I say that is because, again, we have to have the ability to zoom in and zoom out. We have to be able to appreciate the person in front of us, right? We have to be able to appreciate focally as well. So again, there are always going to be so many variables that impact a certain joint. If that's the joint in pain, it could be referral patterns, it could be systemic, it could be, other things we have to consider are like occupational history, your current sports history, what are you doing from a training standpoint, like the list goes on. And it's really important to appreciate even the confounding variables as well that we're not even aware of.
Sure.
When it comes to somebody in pain, it's really important to appreciate, how are they moving? What spaces do they have available? How are they absorbing force? How are they producing force? And all of these things have to be considered in its entirety when we're looking at somebody.
Yeah, I mean, I think that at the end of the day, we need to say, does that information change how we want to treat something? Right. Like I actually frame this exact question to patients all the time. It's like, listen, I'm not telling you that this definitely is not this. I don't have x-ray vision. I can't tell you that. But if I had to ask you, let's say we were to find out that this was a herniation. Is there anything based off of how you feel right now, based off of the changes we're able to make in the clinic and based off of the activities that I'm able to prove to you that we can do pain free? Is there anything right now that would make you want to try to treat this through surgery? And typically someone's eyes go wide and they go, well, no, of course not. I go, okay, great. So what is that information going to do for us? Genuinely, like how is that going to do anything for us?
Right.
And then
absolutely.
Right. And then I love kind of framing things geared around money, right? Because everybody likes to talk to us about like, investments and things like that in their health. It's like, okay, well, let's say insurance didn't cover that MRI. Would you still feel like it's necessary? Would you still want to pay $2,500 for that bit of information? Or is it just because, it's covered?
Right. Absolutely. And like, even like when we'll stick to the herniation example, like if a patient is, their disc is herniated and they're like, oh my gosh, I'm screwed. I'm in pain all the time. If we put you in positions that don't hurt, it's like, where did that herniation go? Right.
Right.
And then they start to really, really think about it. And again, it's not like a death sentence.
Sure.
You just have to be able to assess the whole person and put them in positions in which they can succeed. And then from there, build out their whole plan of care.
And I think that we have the luxury of being the conservative clinician, right? Like, the worst thing that could possibly happen if you were to try PT and it quote unquote failed or did not get you where you want was, okay, then you go and you do that next, a little bit more invasive type of procedure, right? We have the luxury of safely failing. Whereas if you were to go a little bit too extreme first and that didn't work out, obviously, there's more risk involved with the more invasive stuff. So we do naturally have some built-in luxury within our profession, right? But whether we're talking about herniations, whether we're talking about other like, well-known words like sprains and strains and this and that, those things matter to an extent. And where they matter is almost telling us what not to do. Right. Yes. I think they're more helpful in telling us what not to do. But at the same time, guess what? Like your symptoms would have told us what not to do if we were paying attention. So, when you're working with a skilled clinician, like while I'm not saying that symptoms are everything, pain tends to be that like kind of fire alarm that tells us something is off. Like my body doesn't like this. I'm not loading the structure the right way. We're doing too much, whatever the case is. So if you're paying attention, if your body is not hurting and that is not enough information, but you are feeling the right structures working or the right structures absorbing those loads that you're working on, then we are loading that joint, that tissue appropriately, and then tracking things over time and seeing how your body responds in response to that, and not just making these very like blanket general statements allows us to know whether what we're doing is appropriate or not. So I think that also touches on another point is like a lot of people have this belief that, I have the tendonitis, right? So I can't do this exercise because it's going to make it worse. And it's like, I'm sorry, but like what we're doing is skilled and intentional and with purpose. So I respect that mindset, but it's only making it worse if it's making it worse, in which case that means that I chose the wrong thing or you did it wrong. And both of those things would be my fault. So that would be my fault as the clinician for not being able to catch those things. Right. Like, so it's kind of like, I think it still comes back to fear, and it comes back to the lack of education that makes that mindset hard to almost reverse, so that we can show people all that matters is, can we identify how we're moving that could kind of tie us into understanding why this injury happened, why you put that stress in that area, why potentially that structure failed in the way that it did. And do we have the potential to influence that to allow you to express all your different movements without pain, right? Like that's
Right.
that's the only thing that matters. If you can do every single thing that you want to do without pain, would you have ever even thought to get an x-ray? Of course not, right? That's an easy question to answer. So, if we can think more like goal oriented and not think, I don't even like throwing the word fragile, but like not thinking more of like the fragile mindset of like focusing too much on the medical diagnosis, then, we open up the possibility of getting better.
Absolutely. And, as providers, I think, you touched upon this briefly before, but our words matter and how it's perceived matters. There were many times where people would come for a consult and, one of the most common things they would express to me is, they went to the doctor and, they didn't present normally when it comes to like a certain diagnosis the doctor is looking for. So as a result, the doctor told the patient, you know what, this might be in your head. Now I'm just going to pause right there. Like, how damaging is that to the person, right? Like, if you are told
Sure.
that, you are crazy and you are just making this stuff up, it's like, who do you end up trusting? Like, you can't trust anybody anymore.
Right.
So as a result, like when we come across that, we have to flip the verbiage, flip the way they think, and it becomes double work. Now, not that that's a bad thing, but I think overall as practitioners, we all have to do a better job of not catastrophizing, but giving
Yes.
people hope and allowing them to see that they have the ability to get better. Now, if it's a tear, okay, you're probably going to need surgery. But if it's generalized pain that that you're unsure of, again, just take the time to look at the full body instead of just telling them, this is it, because that's essentially what happened to me too.
Right. We need to realize, I think it's really hard for, again, we're just going to say blanketly like clinicians, right? So this is across all of healthcare.
Yep.
I think it's hard for everybody to appreciate the role that we have on the psychological side, right? I think that a lot of times clinicians get very caught up in their specialty or in their role. And it's probably the reason why people are very good at very specific things, but they forget like the human side of it. They forget how to communicate. They forget they're talking to a human. And they don't understand how to take a step back and put yourselves on the other side of the conversation, right? And it could be something so small, or it could be talking about very difficult conversations, right? And either way, there is no benefit to, like you said, catastrophizing the situation, even if it were really significant. The only time I would say that it might be is if you felt like you had to be forceful to get somebody to kind of, really hone in and do something that you're trying to tell them, right? I think there's times where, we know patients like that like really need a kick in the butt, right? But
Absolutely.
but we're talking about those other times, right? The amount of times that, almost to the point where it's obnoxious, like I don't allow people talking about like their bad knee, right? Or their bad shoulder. Like 100% of the time that I hear somebody say that, I correct them and I say, you mean your right knee, your right shoulder? And, the people that don't know me yet just look at me. They're like, no, my bad side. I go, no, your right side. And we'll go back and forth for a while before they roll their eyes and go, okay, I know what you're saying. I get it. But like, part of it is a joke, but part of it is like, there's no reason to allow someone to talk about themselves like that, because your perception is your reality. If you tell yourself that knee is my bad knee, you are giving yourself the right to not get better.
Mm-hmm.
That should be non-negotiable, that your body has potential for positive change, even if it's taking you decades, right? I do not care how much time it takes, right? Your goal should be to have the greatest amount of potential for your body. And, you get to decide in the moment whether or not it's something that you want to reach for like a professional to help guide you, right? That's a different discussion, right? But when you use these terms to describe yourself, you are no longer giving yourself the potential for change. You have already made that built-in excuse for every single time you feel pain. It's a convenient excuse, right? Because you also don't know if that's the reason why it hurts, right? That old knee injury when I played basketball in high school, just because it's the same knee does not mean it's because of what happened in high school. I'm 33 now. A lot more has happened in the last 15 plus years, right? Like, how convenient would that be if it was just a dumb luck injury 15 years ago and I just completely gave myself that cop out, like, oh, nothing I've done for the last decade plus has a role in why I'm feeling pain, right? So like so much of what we do, yes, we care about obviously getting people out of pain and educating them on how to move better, this and that. But it's like we need to appreciate the mental side of this too, because so much of what people tell themselves, that is their reality. And that is always going to handcuff people if we can't make changes there just as much as trying to make change on the physical side.
Absolutely. No, you nailed that on the head.
Moral of the story is, medical diagnoses, like they serve their purpose. But, in the outpatient orthopedic realm, kind of like this, we'll call it non-specific pain, they're really not as important as people give credit to. So, yeah, I hope you guys found this helpful. Hopefully, if anyone's been dealing with any type of chronic or recurring pain, maybe this gives you a little bit more hope that you do have the potential to get better. It's going to start with you. It's going to start with your mindset. And then it's going to get down to like working with people that really know how to get away from the diagnosis and start understanding the why. Thank you so much for catching today's episode. If you liked it, save it, share it, and leave a 5-star review. It helps us get the message out to more people just like you. We'll see you guys on the next episode.